welcome back. We have Dr. Pleskow here. He's going to talk about their case. It's an indeterminate biliary stricture with cholangioscopy and AI.
Right. Thank you, and welcome back to Beth Israel Deaconess Medical Center. In the room, I have Kasim, who is one of our advanced endoscopy fellows, and Dr. Boston is my partner in crime here as well. So let's get to the case. So we've already taken out our stent, and I want to show you the cholangiogram. So if we can go to the fluoro image, please. And we have cholangiogram here, and we're going to inflate the balloon, G, and we're going to inject a little bit more contrast. And here you can actually see at the takeoff of the left system, there's what appears to be some obstruction. And on the prior cholangiogram that we saw here, it looks somewhat mass-like versus even a square stone. So you can see the right-sided biliary tree looks pretty good, but the left side, you can see the very, very narrow channel that's going out here. So I suspect that there is either going to be a mass or a stricture here. You can see this left side now filling up. So can you see that well on your images, or is it hard to see?
We can see it.
Okay. So the next step is we're going to advance the cholangioscope, this Dragonfly, which again is a newer cholangioscope which is on the market. Which works a bit differently than the currently available instrument. And as Aman was showing you, this is attached to the scope. The entire unit is attached to the scope. Let's show my hands right here. It's going to get attached to our suction channel. And then to advance the scope, you actually push down on the instrument, and it will extend the scope into the biliary tree, rather than just using the scope to push this out. Yeah, so we're going to take this out. So the first thing we do is we take off the traditional suction channel cap. Now this is a it's a flexible tip as well.
So we can see what you're doing there?
Yeah, of course. So you have on my hands, we're going to, G is going to put this cap on. This cap comes with the Dragonfly and gets attached to the suction device. And this is where now the Dragonfly will attach right to here. And we'll show you that in a moment. We're going to feed this over the wire. If you can, let's show your hands, G. So again, it's a very, very flexible tip. This is going to go over the wire. And then the catheter goes through the channel. And this is going to connect right on top of the scope. So there's that blue plastic, which will come around. It looks like the traditional way to attach instruments. And if you can see this, we're going to point this way. We're going to push this down over the suction channel and then wrap this around, and then it's going to click onto the instrument. This is now clicked on. We're going to remove this yellow locking device off. We need to keep that because that's how we're going to get the scope out. Now I'm going to hold on to the scope, and I'm going to insert it, and it's going to go out to the elevator. And once I get to the elevator, I'm going to open my elevator and start advancing it. And G's going to give me a little bit of back pressure. So if we can have the fluoro image for a second, you'll see how nice and radio opaque this is as well. And I'm going to go up to the area. This goes in very smoothly. All right. Okay, and I'm at about the level of where I want to be because I think this is where the lesion is. You can see here on the fluoroscopic image, we're going to take the wire out now, and let's see what the cholangioscopic image looks like. Now we have two ways to move the tip of the scope. We have this, if we can show my hands for 1 second. So we can just onto here. So this is going to rotate 360 degrees, and this is up and down deflection. So when we rotate this, this is going to rotate. Now, again, these are fine controls. You don't need to turn this and rotate this very much, just short little turns. You tend to use your hands and your body a little bit more with the tool. So we can use torquing back and forth or pushing in and out. So that's how we control this. We're going to control the tip. So let's get a cholangioscopic image. Big? Yeah, let's make that big. Okay, so we have the guide wire out. So let's go look up a little bit more. We're going to irrigate here. And again, I'm going to rotate using very, very small little motions with my hand, and I can use my wrist a little bit to try and direct the image. So up against the wall a little bit here, so I'm going to come back. See if you can see this a little bit better. You can see the ducts going off to the right and the left, so I'm at the hilum right here. And if you could maybe give me a little image of the fluoro on the little screen on the bottom, please. And I'm going to rotate, and I'm going to try and get into that duct that's over on my right there. That's where, go ahead.
Dr. Pleskow, this is Jennifer Fan from Hoag. Beautiful demonstration thus far. Can you comment a little bit about the natural learning curve that you found when using this device, given its more novel mechanical mechanism that you have?
Right. So I would say you probably need, 4 to 5 cases to be able to learn how to use this instrument. Obviously you're going to use it on the outside a little bit just to test it, and you can play with a little bit of the this on the outside through a duodenoscope, and you can have somebody hold it in your hands, and then when you get into the patient, you can then see how it works. It's nice to have somebody who's done this before help you along. So Medtronic is very, very good at making sure that they're there. And you can see here on the right-hand side, I have a little bit of what looks like a little bit of an ulceration on the right-hand side. And I'm just slowly trying to manipulate that up. You can see the images are really very nice here, but there is an ulcer right here. There's a little bit of mass effect as well. So it doesn't look like it's a stone. I'm going to just try and keep going up. Now it could be a stone behind that as well. I'm going to use my tip deflection. And again, everything is slow. You don't need to crank on the dials. And everything moves really pretty well. I got a little bit of a curve, I think, in the bottom. I'm going to try and straighten that out. And then get that up into the duct. Okay, there we go. So using my tip deflection now to get that a little bit into better view. And using my fluoro, I just want to make sure we're going into the right duct as well. And it looks like I'm well up into that duct now. You can see this is ulcerated. There's some pretty ectatic blood vessels here as well. I'm going to try and rotate again to try and get into that duct. This is really phenomenal imaging as well. And I think we could see this pretty clearly.
Hi, Doug. It's Raman. I was just wondering, I know it's kind of early in your experience, but do you see any advantages here? Obviously, it's a nice demonstration of great images in terms of operation, in terms of maneuverability, or what are your thoughts on this sort of new?
Yeah, so great question. I think that the soft tip is really nice. So you can use it if you don't like to use a wire. I think this is very helpful in getting up into the duct. I think the visualization here is really good as well. Maneuverability is good. The other, valuable things that are good here as well is it's a bigger channel, and that allows for bigger biopsy forceps. So the biopsy forceps that's available is 1.5 versus the standard 1.0, and it's got a 6 millimeter needle on the end of it as well, which may be able to grab the tissue a little bit better as well. And you may be able to demonstrate that in a moment to show you some of these biopsies. So it's pretty tight up here, actually. So I'm having some resistance in getting that scope up into the duct. I'm just manipulating my mother scope to try and help navigate up into there. And again, I'm not using the handles very much, but I'm getting some resistance as I'm trying to advance the scope through this area. I am a little bit concerned that there's a malignancy in this area. And I'm just going to come back and get a little bit wider angle here. We're back at the cholangioscopic image, please. So again, you can see slow rotation, which helps to manipulate the tip of the instrument, and you don't want to crank this too much. I'm using the up-down, which is this blue dial, and then using the gray dial to give me slow rotation around, and then torquing my right hand on the on the mother scope to help manipulate things as well, and then pulling back on the mother scope as well to help advance it up into the duct. There's lots of moving pieces, and I think there is, as I said, probably 4 to 5 cases to feel, most comfortable with this. But there appears to be.
Dr. Pleskow, I think eventually you'll biopsy this given the atypical brushings.
Yeah.
Do you find that with a bigger channel, you have to use less technical deviations in order to get the biopsy forceps up to the hilum, that it kind of runs smoother?
So, so we've developed this thing, we call it walking the dog, which Jermaine will open and close the forceps, and we're going to show you the tip of the forceps here against my gown first, which is right here. So we can get a magnification up on that. And you can see that that's keep going a little bit more magnified, please. Open G. Okay, so you can see that's pretty good size. And then a 6 millimeter tip. And he'll show you how we walk the dog. I don't know why we called it walking the dog, but yeah.
Kusami and I were just laughing because we use the same terminology as well.
There you go.
Walking the dog.
So we're going to take off the cap, and then we're going to put the biopsy forceps up. Okay. So that's going up pretty smoothly. I'm going to go to the fluoro machine because usually the tough part is getting this around the elevator. So you want to open up the elevator, but this is going really nicely up over here. If you can't get it, like with the SPY, is you either push the scope up over the elevator with the biopsy forceps in it, or you pull it back, and then you can advance it. So I'm right at the tip. We'll see this coming out, and we'll open G. Okay, and I'm going to advance this. And by pushing this scope up, I think I can get some better pieces here as well. So I'm actually advancing with my hand here, get that biopsy, and it makes it pretty firm. And it looks like we're getting a really good piece here. Close? Good. Okay, now we're going to pull this out. I think we're going to have a pretty sizable piece.
Like it's your olive board.
And then G, if you can show that on the tissue paper.
With
One of-
this device, it seems like it's much easier to pass the biopsy forceps, just probably owing to the larger channel. It also runs through the center of the device, so it's a little more centrally focused. And again, in my limited experience, I haven't had to do that maneuver that you were describing, the walking the dog, with this because it just really can make that articulation around the elevator much easier. It's nothing more frustrating than having to do that maneuver when you've struggled to get to that lesion, like you've shown so elegantly, and then you have to pull back the scope just to get the biopsy forceps down. It can be very frustrating, and so having something that passes smoothly like this is really, as small as that is actually very, very helpful for your frustration level when you're trying to obtain cholangioscopy-directed forceps biopsies.
Absolutely.
So guys, we're wrapping up here. What's going to be your final plan for this patient?
We will take 6 sets of biopsies. We'll go back up, and I always will send off samples for brushings, even though we've already done them, because we'll add fish to our specimen, and then we'll replace the stent, and then hopefully be able to make a diagnosis by tomorrow. We'll send these off to our pathologist. It's really important to educate the pathologist, because if they're new, when we first started, sending them the little tiny pieces that we used to get with the SPY legacy system, was really challenging for them to read. So I'm using forward motion to actually push that biopsy forceps pretty deep, close. And I think we're getting really nice specimens here. I feel like I'm really getting a pretty good chunk of the tissue here.
Okay, we're going to wrap up here, Doug, and have a quick word from our sponsors, and then we'll head to Orlando. Thank you so much.
Okay, thank you.